to give. So Chona is 4 years old girl, came to ER 4 days back with high grade fever, cough, running nose. Today she fainted at home and was brought to ER. Take
High grade fever.
4 years old girl came to ER 4 days back with high grade fever, cough, running nose. Okay. Today she fainted at home and again brought to ER. Take history from Jessa, mother of Chona, and make management plan. Okay.
Okay.
Okay. So now if 4 minutes finish, she'll tell you, you can prepare the template. You can start now.
Hello, good morning.
Good morning.
I am Dr. Adnan, one of the child and adolescent doctor. Am I talking to Jassa, mother of Chona?
Yes, doctor. This is me.
Okay, I am here today to discuss about Chona. So, is it right time?
Yes, doctor. I am very much worried about Chona. You can discuss.
Okay, I will make some notes during our conversation. Is that okay with you?
Yes, doctor.
So, would you like to tell me about Chona condition?
Yes, doctor. Actually, 4 days back, we came to emergency. She had some high grade fever and she was not feeling well. And the doctor examined and told us maybe it's just some viral infection. And they gave us some medication like paracetamol and asked to observe at home. But since yesterday, I see her, she looks tired, excessive sleepy, and also her chest is fast, I feel. Her breaths are fast, I feel. And today suddenly she had this problem, doctor. She fainted at home and I brought her to the emergency.
Okay. So, would you like to tell me more about 4 days back, as you told, there was a fever, how it starts and how it progress? Would you like to tell me more about that?
Yeah. She has high grade fever. I used to give paracetamol for her. It used to reduce in 2 hours. And then again, in 4 hours, she used to get the fever. That means every 6 hours, she was spiking fever. That's all. Otherwise, she was fine with some running nose. Only today, she had this problem, doctor.
Okay. So fever was associated with running nose. Okay. So do you think that anything making it worse or better, this fever?
Only the medication will reduce her, and then again she's going back. But from yesterday, her fever was fine. Today she has this breathlessness and fainting, doctor.
Okay.
Mm.
So what other symptoms associated with that you notice with the fever, abnormal movements or any sweating, anything
No
apart
abnormal
from this
movement.
running nose?
No abnormal movement. She has some sweating. Yes, sweating is there. And
Okay.
no abnormal moments. Anything else you want to ask, doctor?
Okay. So GP told me there was also a cough. So would you like to tell me a little bit more about that?
Yes, she has cough, but there is no, it's not productive. No sputum,
Okay.
just dry cough. And I feel the doctor saw her and told it's from the upper part, like nose and throat, not from the chest.
So it was coming with without phlegm, and there was difficulty in breathing. Did you notice?
Only today, doctor. Only today I have noticed this, not from 3 days.
Okay. Then so during this 4 days, did you notice anything apart this from cough, runny nose, fever, any I mean to say color change of color of the lips or anything
No
on
change in
body?
color of lips. No change color of lips.
Okay. Any swellings anywhere?
No swellings.
Okay. So this cough is coming with any sounds like musical sounds
No
or any.
musical sounds. No musical sounds, doctor.
So this cough wake her in the night.
No, no, she's not waking her in the night.
Okay. So Miss Jassa, would you like to tell me today what happened exactly when she got faint?
Yeah, today we were having breakfast and she came running and I just saw her. She was breathless, and suddenly she fainted. Doctor, that's it. And I don't know. I was worried. I was very much worried. She fainted. She was breathless, and we brought her
Okay.
here. That's all.
Her heart was racing during that.
Yes, yes, yes.
Anything?
I put the hand on her heart. It was racing very fast.
So what did you do for that? You brought her here, or did you do anything at home?
No, no, I don't know what to do also in these situations, really. So I rushed to the emergency.
Okay, you came into the emergency. Okay. So do you think anything she's having swellings around the face or anywhere during this, or any allergic or any
No,
rash?
no allergy, doctor. No, she is not allergic to anything.
Okay. And she was taking only paracetamol, you told me. Apart from this, any other medicines she was taking, do you think?
Uh, no, only paracetamol because the doctor said she doesn't need any other medication.
And she at time of fainting, she was at home or playing outside
No, no,
or
she
in the
was at
garden?
home. She was at home. She was
Okay.
discomfort. That's why she came to me. She was feeling discomfort. That's why she came to me. And I don't know, by the time I was about to address her, she fainted.
So what was her last meal she took?
Yesterday night.
Okay.
Ye-
Okay.
Yes.
Okay. So Mrs. Jassa, I would like to ask now, in the past, she was completely fine before that?
Yes, doctor. No other problems she had. No.
Nothing. Okay. So would you like to tell me about her, how her bowel doing? I mean to say, she's having any throwing up episodes or anything,
No, no
bowel,
throwing, no
any
throwing up, no throwing up,
loose poo?
no loose poo.
So what about her V?
It's fine, doctor.
Completely fine. The color of V is fine.
Yeah, yeah, color of V is fine.
Any during passing V, any pain or any urgency or too much coming V?
No, doctor, I think it's fine. I don't see anything in that.
Okay. Is she's complaining of any joint pain?
Oh, no, no, no joint pain.
Okay. Is she's having any bruises? I mean to say purple rashes on the skin.
No purple rashes.
Okay. So during these 4 days, she was having any sweating, especially in the night.
Yes, I
You
saw.
told me before, yes. Yeah, you told me there was sweating. And this is first time, yes, with the fever only.
Yeah, yeah, yeah. Fever. Yes, yes. She had sweating with fever. And also
Okay.
today I felt she was sweating a bit. But I thought maybe
Okay.
due to the weather. I'm not sure, doctor.
Okay. So she's having any problem with the vision or hearing anything
No, no,
before? Or
no problem with
okay.
hearing.
So in the past, she got any time hospitalization for any reason?
No, doctor. No, she was not hospitalized for any reason.
Okay. Any history of recently travel to anywhere?
No recent traveling.
Okay. Any history of trauma before or during this?
No trauma.
Okay. So any
9 minutes
history?
completed.
So I would like to ask now about, go back to your pregnancy.
Hmm.
Your scans was okay during pregnancy?
Yes, doctor. My scans were okay.
Anything during pregnancy, would you like to tell me that was concerning with you?
Means during
Condition
birth or
cardio?
what?
During pregnancy and during birth.
Uh, yes, when she was born, she was fine, but the doctors only said when we were going for follow up, they said she had some small hole in her heart. But the doctor, they said we will follow up, no need to do anything. It's very small and the child is very fine. Then
Okay.
at the age of 1 year, they again did this jelly scan of the heart and they said it's closed and it is fine.
Afterward, you are following with any doctor for that,
Yeah,
or
we followed up to she was 2 years old. At the age of one
okay.
year, it was closed. Up to she was 2 years old. We were following with the heart doctor, and the heart doctor finally said her heart is absolutely fine. No need for any medications or no need to follow up.
Okay. So apart from this, any concern during birth?
No,
Okay. So would you like to tell me about her growth?
she is growing like her peers. No problem.
There's no concern, and development normal.
Development is normal. Yes.
Okay. So she got her jabs.
Yes.
Any extra jabs?
No extra jabs since she's normal. They said no need for any extra jabs.
Okay. Tell me about her appetite, feeding. How she was that
Yeah, she
about
was
that?
fine. Before 4 days, all her appetite was fine. Only from this time, these 4 days, she's not eating a bit. She's a bit eating a bit less.
Bit less. Okay. Okay. Then would you like to tell me about your family? Can you describe about that?
Yes, doctor. I have two children. One is Chona and another is 3 years or 2 years old now. The another one is
Okay.
also fine, healthy. No problem with the child.
Okay.
Uh,
And your husband is from your family, same family?
no, doctor, we are not related.
Okay. Okay. So anyone in the family, any sudden death in the family before in your
No,
history?
no sudden death in the family.
Any medical issues in the family?
No, doctor, we don't have any problems in the family.
So would you like to tell me about your financial circumstances?
Uh, Financially, to manage both children, I am fine. Actually, we are separated. My and my husband are separated. We are not
Okay.
together. But
So,
I am managing my children well. I work.
so how you are coping with like now he's here in the emergency, and who is taking care of other child at home?
My mother. I have arranged my mother to take care of my child, other child,
Okay.
who is 2 years old
Okay.
now.
Sir, would you like to tell me what kind of difficulties you and your family are facing regarding this condition, like in 4 days? Any
Actually,
specific worries?
no. I already came to the emergency and they told it's a viral infection. She will have several viral infections before also. So I thought it's a normal. This is the first time something is happening for her, doctor.
So for that, did you follow with any doctor? She's having again and again this viral infections. Or she's
Not very
anything?
frequently. Not very frequently. Her
Okay.
last infection was 6 months back. So
Okay. Okay.
maybe
Is
once
she's
or
going
twice.
to school?
Nursery. We have just planned to put her in nursery. Still, she is not
Still
going.
not. Okay. So tell me about her sleep. As you told me about this little bit, she's more sleepy. Apart
Yeah.
from this, any worries?
Only she's only I don't know. From 3 days, I felt that she's little more sleepy because maybe she's not active. She wants to sleep because she's tired.
And
Tired.
how is her behavior? How's her behavior with you and
14
little bit
minutes finished.
irritable or something like this?
14
Okay.
minutes finished.
Okay, finished.
Okay.
I'm finished. So
Okay. Today,
your case.
so today I have taken history from Jassa, mother of 4 years old Jonah. and she's presented in emergency room with complaint of fainting episodes. She was having high grade fever with the cough and running nose 4 days back, and for that she was taking paracetamol. She has been consulted to her GP, and GP prescribed this paracetamol, and that was GP told her that this is common cold, viral, and she was taking only paracetamol. With paracetamol, fever was settling down. But now today she got all of a sudden loss of consciousness, and she presented to in emergency. In the background, she's having while she was in the neonatal period, uh, jelly scan was done, that was told that she's having some hole in the heart, but Jassa did not tell me what was exactly that. For that she was following the doctor, and after at the age of
What?
1 year, that was closed. And in the background, this is single mom separated, and there is no family history of sudden death or any medical issues, and there is no financial circumstances as well. And the child is a little bit more sleepy, and mother has planning to put her in the nursery. Still she is not going. So putting all together, my I will give you a list of differential diagnosis at this may be a possible cause of viral myocarditis.
Okay.
Okay, and I will keep it here also the pericarditis. Okay,
Uh,
and I will keep it here also septicemia and leading to the septic shock and pneumonia, and dilated cardiomyopathy as well.
okay.
Okay.
Okay. So, how do you want to investigate and manage this case?
So, well, considering my diagnosis, and she came into the with fainting episodes. So, first of all, as I have taken history already, so I would like to examine her properly and check the vitals in the form of heart rate, respiratory rate, and blood pressure of as well, and the temperature. Would like to check his at the bedside oxygen saturation, if oxygen saturation is okay or not, and would like to do for BSR as well as. And my approach will be first to stabilize the child,
ESR, what is ESR? What you said?
blood sugar. Sorry.
Okay.
So I would like to check the blood sugar as well, and capillary blood gases. And I would like to first of all to do the management, as the child is coming in the emergency with fainting episode. So my approach will be airway breathing and circulation. After scaring the airways, I would like to check the oxygen saturation and required oxygen or not, and would like to check for the circulation, definitely scare IV line. And
Okay.
yeah, then I will check after, sorry, after stabilizing the child. So I would tell my consultant, involve my seniors as well, and would like to do some blood test like in the
Test
form of
got to
CBC,
run.
CRP,
Okay.
CBC, CRP, and LFTs, RFTs, and urea electrolytes, and would like, considering my diagnosis in my mind, would like to do cardiac enzymes as well, but after informing to my seniors, and would like to involve the cardiac pediatric pediatrician as well, cardiac enzymes, and would like to do chest X-ray, ECG, and the echocardiography.
Can you
In
tell
ECG,
me what are the okay, cardiac enzymes? What cardiac enzymes you will do?
so cardiac enzyme like I can do the CKMB,
Okay.
and I can do LDH. So they can be raised, and also can be done drop eye and uh, yeah, drop
Okay.
eye and these.
Okay. So, okay. In X-ray, what do you want to see? What do you see in the X-ray?
Yeah, if like as I am considering this is viral myocarditis or maybe pericarditis and pneumonia as well. So cardiomegaly can be there in the chest X-ray, and if it is involving the lungs, so there can be some pathology like the consolidation or something like
If it
can
is
be there.
myocarditis, what do you see? Cardiomegaly, what else?
Yes, cardiomegaly can be seen, and what else can be seen?
If
No,
the
I
child,
don't.
if the child in failure, you can see pulmonary edema.
Yeah,
Okay. Next, the
pulmonary
in
edema,
ECG,
yes.
what changes you can see?
ECG, especially in myocarditis, will be changes in the ST segment depression and T wave inversion can be there, and there can be changes in the Q waves and QRS.
Okay. Echo, usually
Echo will, uh,
echocardiography, yes.
yeah, echo will help me to locate, especially for the check for the ejection fraction. As in the myocarditis, ejection fraction, it will affect the ejection fraction, and ejection fraction can be low.
Okay. So what else you want to do in the investigation?
So investigations like in but nowadays they are not doing this cardiac catheterization through that. Biopsy can be taken, and that one can be checked, but they are not doing these.
Okay.
And viral PCR, as I'm thinking of viral, and in also after considering that septic shock or septicemia, so would like to do some blood culture sensitivities and urine culture sensitivity as well.
Okay. Can cardiac MRI be considered in these patients?
Yeah, cardiac MRI as well. Yeah, yeah.
Okay. Why it is important cardiac MRI?
Uh,
Okay. No
y-
problem. So now this patient, if this patient is diagnosed as acute myocarditis, and so you did the ABC vitals, you have started her on oxygen. So what else is your other managements? Please go ahead.
Actually, for there is no specific cure for the myocarditis, and first of all, educate the parents, and the supportive treatment can be given as we will
Yes,
admit these,
supportive
yeah,
treatment.
these children in the ICU,
Okay.
and definitely we'll have to attach the cardiac monitor. We'll have to monitor the blood pressure, and definitely blood pressure and respiratory rate and heart rate vitally, and if required, inotropic support can be given in the form of dopamine or dopitamine, or milrinone or epinephrine.
Okay.
These can be given, and if required, antibiotics if supra-added infections are there. As in my differential, there is septicemia. So after consultation with my seniors, would like to start antibiotic as well. And uh, there are can be used steroids, immunoglobulins, IVIG, I mean to say. And if child is in failure, so then definitely diuretics and AC inhibitors can be started.
Okay.
And if she required mechanical support, it can be given, but it depends condition of the child.
Are they
And
using
if she,
steroids and this IVIG in these cases routinely?
yeah, they this is controversial about the steroids and the IVIG. Some centers they are using, in some centers they are saying no.
Uh,
So
Depends.
all
So
these, yeah,
it's you
all these
involve
will be
the
depends upon.
cardiologist. So here the
Yeah, all
cardiologist.
these will be depends upon my seniors after my seniors consultation. And definitely the management will be in the cardiac ICU or in the ICU with the consultation of cardiac doctor.
Okay. What are the complications?
Well, complications. Okay, complications of acute myocarditis. One of the complication is the dilated cardiomyopathy can be there, and these children's these may lead to heart failures, and sometimes this arrhythmias can develop, and other these are complications regarding to the heart, and other complications regarding to the like they may have problems with the renal problems. These children may go into acute renal failures if it's not
Okay.
improving,
The reason for acute
okay,
renal failure?
as output cardiac output will be decreased.
So
So
cardiogenic
this will
shock.
be, yeah, pre-acute renal failure, pre-renal failure, I mean to say.
Yeah, it may be due to cardiogenic shock.
Yeah, cardiogenic shock, definitely.
What advice you want to give to parents?
So for that will be first of all educate the parents, and the second thing is that uh, have to give the advice like follow up, compliance to the treatment, compliance to the follow up, and avoid strenuous exercises, and
They have to limit
what else?
activity for
Yeah, limit activities. Yes,
yeah, their activities has to be limited
yes,
for several months till they are okay.
yeah, they are okay.
Okay, what about their recovery?
Yeah, mostly actually it depends upon the cause. So most children recover completely, and still there are some children they may have like complications which I have told you. So it depends upon the cause of and how the management initial management has been done. So if there is no treatment has been given, there is 50% mortality. But with treatment, most of the children recover with the passage of time, and some may have some uh, residual heart diseases. So it depends upon the cause, and it depends upon how much cardiac muscles has been damaged during this episode.
Okay, which are the common viruses which are associated with viral myocarditis?
This one can be adenovirus. Coxsackie virus is the most common, or enterovirus and adenovirus. Most common, I think, Coxsackie.
Okay.
This one I have to check.
Yeah, most common is Coxsackie. So, would you like to? Why do you think this may not be a rheumatic fever?
Well, it can be, but there is no history of prehistory of sore throat. Like 2 weeks back, any history of skin infections or throat. So mother has not given me any kind of this history. She was completely fine, and as this is acute episodes, and this is within 4 days she is presenting, and there is no other uh, criteria that is there is no skin rash or abnormal movements which I have asked, and joint pain and joint swelling I did ask. So mother did not tell me anything about that. So if there is a history of 2 weeks before that, any skin infections, or even 4 to 6 weeks for the skin infections, and 2 weeks before for the throat infections, I could consider of acute rheumatic fever as well. But that was not given in the history.
Yes, there is no history of any abnormal movements, no history of nodules or rashes or arthritis or arthralgia.
Yes.
Okay, so it is not supporting, but you can put in the down as
Yes.
it not supporting. Okay. So you feedback for you is, I think Dr. Yasser, did you keep 9 minutes or no for the discussion? I don't know how long the discussion went.
Okay, that's
Discussion
good.
went approximately 10-15 minutes.
Okay, no problem. Because we have
No
to
problem.
discuss more so that in the exam, any question comes, we can answer. This is the reason. Uh, okay, only thing I want to give you is when she said that now she is in emergency, in the history, you did not ask what they are doing now, what they are doing now in emergency. Do you know? This you did not ask. If you would have asked, I would have told you that they are giving her some oxygen and she is on, means.
Actually, that was I was posing myself that I am coming from after examining the child. That's the reason. I was thinking I am in the hospital now.
No,
Like
no,
before,
no,
I have done this actually
no. Maybe
emergency.
no, but here it will not
Yeah,
be.
yeah. No, no, no. You are right.
Yeah. This is what, if you would have asked, I was waiting to tell you that the mother, she's a doctor we brought and they examined her and they put her on oxygen. She's breathless already, is told to you. So she's on oxygen and some, they took some bloods for labs and some fluids have been given like this. I would have told
Yeah,
you.
yeah, yeah,
You
yeah.
would have got to know that there is some acute emergency going on. So she's on oxygen.
Yeah,
If
yeah.
sometimes they will also tell you, parents will know about nebulizations, right? So they will also
Yeah.
tell you. And also, since there was breathlessness, some asthma history also you would have asked, like any family history of asthma in home, particularly you can ask, because
Yes.
breathlessness, right? Breathlessness
I
and
particularly ask about, inquire about the all systemic inquiry for the rheumatic and others, and particularly ask for the events like ample. You know this one ample, yeah.
yeah, this ample you are telling from pals.
Yes, yes. So I especially ask because this was an event and she's coming into the
Can
emergency. So
you
that's
revise us
my
this
focus.
ample? One thing I remember, last meal for L. L is last.
Yeah, last, yeah, A is allergies.
Okay.
Okay,
Okay.
and then is what coming M. M is medication,
Yes.
medication, and P is past medical history,
Hmm.
last meal, and E is events surrounding that time. As I asked,
Yeah,
she
yeah,
was
yeah.
in the hospital, she was ground, or she was where she was, what she was doing at that time. So I particular ask about the ample, and I took the history to rule out my differential as well.
Okay. Otherwise, I think you covered everything. For me, I did not. I wanted you particularly to ask only about it. Okay. Regarding the cardiac MRI, we were talking. Most of
Yeah,
these
that's I don't know.
will be.
Actually, I did study today from different websites, but I was not satisfying. So I then stopped. I said, okay, no problem, which I know I will tell.
No. Actually, here nothing. You don't say too much. Only this much is I will tell you. I will read for you. I made the notes. One is
Okay.
you read this. Wait, before that, let us take others points and then let me go. So this was the only feedback from me. Another Dr. Yasser, you have any feedbacks?
But everything is fine. Nothing specific for him.
Okay, he covered everything.
He
Okay.
covered everything. But my question is this one regarding the rheumatic. It could be rheumatic heart disease, but we have to say we need examination. Fever is there, and one minor. We need two minor, and maybe the laboratory acute and examination, because we did not examine the
Fever
patient.
actually, mother said that is settled now.
No, 39. She told the 39.
Yeah, first day. That was first day. She said now fever settled. I have written. That's why I was excluding that one
No.
completely.
Actually, yeah, rheumatic heart disease is a differential here because one
Rheumatic fever.
point you have,
Rheumatic fever.
sorry,
Not
rheumatic,
rheumatic
Mm.
heart disease.
yeah,
Rheumatic fever we can put here.
yeah.
Yeah, rheumatic fever can be
Rheumatic
considered.
fever can be differential here. One is there is carditis and there is fever. So you have one major criteria you got and one of the minor criterias. And also suppose ESR, CRP is elevated can also support you. But the other things are not there here in the history. So you can put it, but put it as second.
Yeah, yeah.
Okay, because there is also, along with, even if you have all these criteria, the evidence of
Which,
streptococcal infection is also important, right?
which I forget particular. I have written in when these 4 minutes I have written, but in flow I did not check.
Not tell the rheumatic fever. So keep
No, no,
rheumatic.
no, 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 no. I will tell you which particular I want to ask about the corona. These people's these days now babies, if they have corona, they are presenting like myocarditis. Especially I want to ask about this.
Yes, you're
I
right.
have written this one.
Corona.
Dr. Adnan, it could be multisystemic inflammatory syndrome.
Yeah, multisystemic inflammatory syndrome can be there. So I want to ask is so that it will be cover each and everything. I have written even, but in the flow I did not check on the paper.
No problem. Now let's go to the investigations. In investigations, you rightly said CBC. Usually, what do you see in CBC? Maybe some leukocytes.
Like if it is viral, so there will be some kind of lymphocytosis can be there.
Yeah.
Or
So
leukocytosis.
And other is sometimes there is low hemoglobin in some patients.
Yeah, low hemoglobin, definitely. Yes, you are right.
okay. So and also ESR CRP can be elevated also. Okay.
Yes.
ESR CRP and urea electrolytes as routine you will do, because there can be some hypotension, and also LFT as routine. Then the main cardiac enzymes now you will tell is all these LDH and all is old. Now you will tell is creatinine kinase, TROP-I and TROP-T. CKMB also.
Yes, TROP-I.
CKMB, TROP-I and TROP-T. And all these LDH and brain natriuretic peptide, I think you can say, but they are old now. The more urgent means the within 24 hours elevated
TROP-I will be raised, and TROP-T, I think I don't remember this one.
Anyways, the main cardiac enzymes now you tell is CKMB, TROP-I and TROP-T. Okay, leave rest of the things. Okay, so cardiac enzymes.
Dr. Noor Malish, where you have read these TROP-I and TROP-T?
From patient info.
Well, okay, because I was thinking it is from the adult. Before, although they are doing.
No, we are doing. Wait. Let me tell you. There was a patient recently. She had corona infection, and it can be she has corona infection, and she was 10 years old. She had Kawasaki. Okay, and also she had coronary artery aneurysms, and she came to me in our ER. And she had chest pain. We did TROP-I for her from the lab. Okay, so they
we are doing BNP.
Huh?
This brain natriuretic peptide, BNP.
I think it is old now. Mainly they are doing TROP-I in our hospital.
Okay, I will check also.
Yeah, in our
we are also doing TROP-I and TROP-T, but mostly they are from ischemia. That means
my friend daughter, she got this I think dilated cardiomyopathy. After that she got acute myocarditis. They have done this TROP-T and TROP-I also.
No, in our hospital they are doing, and it is mentioned in patient info also. Acute myocarditis, I think it's common in children, viral, post-viral.
Actually, this TROP-I is showing ischemia of the wall.
Okay, there can be some, okay, this can be negating to you that there is no ischemia also, right?
I will check again, okay? I will check again also, okay.
Let me tell you, I wrote somewhere also. Okay, tell CKMB, TROP-I and TROP-T, okay? I don't know about BNP, you will tell or not, and also LDH, it's your choice.
Because BNP is a part of this corona-associated multi-inflammatory syndrome. Nowadays, they are presented with just like atypical Kawasaki or Kawasaki.
No, I want
BNP also for the specifically for the heart failure.
Whenever we tell anything, please, the reference should be from the UK websites or from this. If you tell BNP they are doing for corona, you should give me a reference from the either from NICE or from any of the UK recent textbooks. Okay, whatever I write will be from the recent ones, either patient info or from illustrated textbook.
One thing only I will add here, this corona associated with this myocarditis and other things, their treatment is just like Kawasaki, but they are starting methylprednisolone in the beginning. Just
Actually, there is a protocol.
they will ask you.
Dr. Adnan, there is a protocol. Initially, they started immunoglobulins, if not, just like Kawasaki, there is a protocol.
Just like Kawasaki, but in Kawasaki, we know this IVIG, we are starting after IVIG, if not improvement or there is any allergy, we are giving the methylprednisolone. But in if there is corona associated with that, so they are starting in the beginning. This one just today I studied.
Okay.
I will send you an
Where
article.
you read, Dr. Adnan?
This one
Dr.
UK.
Adnan, I will send you.
Just maybe I have this one. I have to
No,
search.
what I am telling you is for this exam, see the practice 1 minute. No, my question is, even in inflammation, they can rise or they cannot rise?
Yeah, they can rise, definitely.
Yeah, this is inflammation. If not infarction, this is inflammation. The other thing is you can see cardiomegaly in chest X-ray and pulmonary edema, and also sometimes can be pleural effusion, but as a part of heart failure. Okay, but rare. Don't mention this. Mention cardiomegaly, and if there is heart failure, pulmonary edema, more than enough. Okay. Then for the viral, you will do two things: viral PCR and viral serology. Okay.
And one more thing, when you ask me, I forgot to tell that advice to the mother also about the dental hygiene, because we don't know after that what she will develop the complication.
The other causes of myocarditis, what are the other causes other than viral?
Other than, there can be bacterial causes, there can be fungal, spirochetal causes, some poisoning drugs.
Yeah,
like
this
diseases
like scleroderma or
yeah.
And what is that?
These scleroderma is coming. Yeah, SLE, scleroderma. So, scleroderma is coming in old peoples.
Yeah,
usually.
But sometimes if you want, like if you suspect SLE or something, you can send the antibodies.
Connective tissue disorder, simple say connective tissue disorder.
Yeah.
What?
These are all are connective tissue disorders, na?
Yeah.
SLE, yes, this.
So some connective tissue disorders, if it is related to your case, you can say, otherwise no need. I'm just telling you only. So as you said, Dr. Adnan, it is the endomyocardial biopsy is the gold standard, but it is not performed nowadays. They usually do cardiac catheterization and take the biopsy, right?
Yes.
But usually it is not done, as you said. And cardiac MRI, why they are doing is to differentiate the transient and permanent tissue damage, like it is just inflammation or infarction. Okay. Yeah. So the differential is acute myocarditis. What you want to differentiate is it just myocarditis or there is myocardial infarction? That's why they are doing whether it is transient or permanent. So that means here, I think in inflammation also the cardiac enzymes will be raised. Okay, just go back and check. In myocarditis, what will happen to cardiac enzymes? If TROP-I will get raised only with infarction, then it should not be raised in myocarditis. Okay. What differentials you can put is, yes, you're right, myocarditis, dilated cardiomyopathy. Other causes of congestive heart failure you can put. Pneumonia can be bacterial and viral. And also in the last, you can also put myocardial infarction. Okay. Because it can present in the same way with chest pain, breathlessness, sweating. Okay.
Yeah.
But as myocardial infarction is rare in children, if you want, you can say, otherwise no need. Advice to parents after recovery from acute myocarditis, limit activity for several months. For several months, they have to limit activity. Again, complications is same like your differentials. Dilated cardiomyopathy, congestive cardiac failure, pulmonary edema. Arrhythmias, I don't think if you told arrhythmias or not in the
I told this one.
Okay, then it's fine. So the prognosis, as you said, depends on the clinical presentation and also depends on the left ventricular ejection fraction in the child.
Yes.
Okay, these two things, clinical presentation and left ventricular ejection fraction. As you very well said, so always start with ABC, check vital signs, because this patient, and you will involve immediately after ABC, check vital signs and collecting the blood and starting IV fluids. You will ask for involve your consultant and cardiologist. Okay, admission to ICU for monitoring, cardiorespiratory monitoring and monitoring of the ejection fraction. Okay.
Yes.
Ionotropic support, dopamine, dobutamine, epinephrine. This milrinone means what? You are telling milrinone?
They are using for this in
They are using?
cardiogenic shock.
Yeah, in your hospital they are using, or are you familiar
No,
with?
no, no. Before when I was working in ICU, we are using this one.
Where?
This is
Here.
milrinone is enodilator. They are using in the cardiac patients, like in the heart failure or.
Yeah.
Yeah. Yes, Dr. Rehana, again, please tell me about milrinone.
Milrinone is an enodilator, like epinephrine is a inotropic support for the cardiac patients. This milrinone is for enodilator. As like if your patient has like with the cardiac failure with cold peripheries and they are like in with shock type of cardiogenic shock, they start this.
So it's
What is the side effect of milrinone, Dr. Rehanna? What's the contraindication for milrinone?
But it depends upon the which type of shock you have. Then they will not start. If it is like
Hypotension.
there is one hypotension.
Hypotension is the side effect.
Hypotension. If there is a hypotension, then you will not start. You will give epinephrine.
So see this, if hypotension, you will start this dobutamine, dopamine or epinephrine. Okay.
Yeah. Dopamine.
Yeah.
Because in the periphery hospitals, you don't have epinephrine, they start dopamine, dobutamine. But in tertiary hospitals, they directly start epinephrine.
It actually increases contractions of the heart
yes,
muscles.
heart. Both actually for the epinephrine, both contraction also, and it will improve your like hypotension. If your patient is hypotensive, it will increase your blood pressure also. And also it will increase the contractility of heart. That's
so milrinone is mainly for the venodilator. If there is
venodilator, if it's like cold shock, patient is having cardiogenic shock,
it can cause this hypotension and arrhythmias also. Just now I checked.
So I think better we will keep ourselves to ionotropic support. Dobutamine.
Yeah, I don't think so. You need to mention one by one. You can just say inotropic support. Inotropic support can be anyone: dopamine, dobutamine, epinephrine.
Actually, no, this time on 28, I think was the exam. Yeah, 28. So the same scenario came. Same scenario. You know, this one 3 days back, and she's having fever and 4 years old child and got fainting.
Was this milrinone asked in the exam?
Yeah, they ask how will you manage. So then ask about which inotropes you want to start and how will you start, and each and everything ask.
Just names, right? No doses.
No. Doses they don't want. UK, you know.
The candidate mentioned about milrinone also.
No, I did not ask. He said that inotropic sport. Then I told each and everything like dobutamine, like this. He was giving me the feedback only, not complete feedback. Like.
Okay. Anyways,
don't make yourself. If they ask, then you can say inotropic support. If they ask you what type of medication, then go next step that one. Because if you will from the beginning, like beginning only, you will start like saying milrinone, epinephrine, it will become complicated. But if we say inotropic, it's a broad heading. When they say which type of medication, you can start with dopamine, dobutamine, like that.
Yeah, most common is the dopamine and dobutamine.
Most common is starting everyone, like all the patients who comes from the peripheral hospitals to the tertiary, they will come with always dopamine, dobutamine. Because they don't have the other like milrinone, epinephrine.
Patient came in emergency, so always start from my
yes,
after
dopamine,
taking
dopamine.
ABC,
Yeah. After
after
fluid
taking
balance.
the vitals, ABC, scare IV line, take the bloods, then we'll start sporty management like inotropic sports to support blood pressure.
First to
Myocarditis.
resuscitate with bolus, fluid bolus.
Yeah.
After fluid bolus, if they don't respond, then go for inotropic.
Okay, I want to ask you one thing, Dr. Rehana. Here the fluid bolus will be like 10 ml per kg, right? Small.
Yes, yes. You will give 10. You will give 10. You will give in cardiac patients. You will get. If non-cardiac patients, you will give 10.
Yeah. So
But you can repeat also. If you have consultant with you, you can repeat.
Okay, so even you are suspecting some cardiac pathology, still you can give fluid bolus. And
you can give. You start with 10
potential.
ml. Like we start, sometimes we give to 10, 20 ml. If patient is in shock, we give 20 ml. But here in the cardiac patients, we start with 10 ml.
So for cardiac cases, usually 10 ml per kg.
Yes, yes, 10 ml per kg.
Okay, so just for my knowledge, I will ask you. So now, what is the difference between this epinephrine and milrinone? You said
milrinone is only enodilator. It can just peripherally, it will warm up the baby. And but the epinephrine, it is eno and chronotropic and inotropic, because it will increase your perfusion and also it will increase your the cardiac contractility. So if like cardiac contractility is compromised, heart rate is low, it will increase the heart rate. Heart rate will increase. And definitely if when heart rate increases, you will have more better perfusion also. So that's the perfusion also. Yeah, because when heart rate is low, then baby is compromised with the perfusion. But if it is like going up with the epinephrine, when you start with them epinephrine, heart rate increases also. So it's both effect, eno and chronotropic, both for the peripheries, both for the heart also. Heart, it will increase mainly the heart rate, contractility.
No, the most are these things: dopamine, dobutamine, and epinephrine. Better to stop with them. And then, as you said, antibiotics.
Yeah, as you said, dopamine, dobutamine is the main, because everyone will have this type of facilities, but all the people will not have the milrinone and epinephrine. You can just start with we will go with the inotropic support. Inotropic support, if they ask which type of medication, then you go with dopamine, dobutamine initially.
So basically start with admission to ICU, and also you can give the fluid bolus and then ionotropic support, then antibiotics,
yes, exactly.
fever, and start with antibiotics, and steroid and the intravenous immunoglobulins, keep it at the last. It's not common. Okay. Then for heart failure, you will tell for diuretics and ACE inhibitors. Then if there is any arrhythmias, you will go for antiarrhythmic drugs if child has arrhythmias. Otherwise, no. The role of steroids and immunoglobulins is controversial, so it depends upon the cardiologist. Then here the mechanical ventilator support if they need. Okay, and even in this, the ECMO is mentioned even in this.
ECMO they are using. Dr. Rehana will tell us more about.
Dr. Rehana.
Yeah, the last option they will ask you last option. If your patient doesn't improve, then you'll say, if I have facility of ECMO, I will put patient on the ECMO. What is ECMO? It is you will give the relax to the heart. You will give the like bypass machine in the one we are doing for the cardiac surgeries. You put patient in the bypass, and then you relax the heart and you do the surgeries. Likewise, only you will relax your patient's heart here, and you will support him with the ECMO. It will be like circuit of the blood going in and coming out. It's like that. Exactly like what we have in the bypass pump in the surgery, cardiac surgeries. When you do what you do for the cardiac surgery, when you take the cardiac patient for the surgery, you will aorta, they will clamp. That means they will relax the patient heart and they will do the surgery.
So ECMO
Similarly for the ECMO, they will put the cannula in the aorta and one in the lungs. Sometimes they do both cardiopulmonary. Sometimes they do only pulmonary. If the lung pathology, like in ARDS, They can do only the pulmonary ECMO. But the cardiac patient, mostly they do both cardiopulmonary ECMO.
Okay. So what I understand is, if needed, it's like a bypass, giving the rest to the heart and the machine.
Yeah, giving that. This is the main thing, because you will realize you will rest the heart and lungs. You will rest, and you will give him the outer support for the patient. You will supply your blood to the patient by the cannula.
Okay,
this is
the last
running with that machine. This is the last option. This is the
last option. Yes.
Yeah.
So anyone else read from any other source you want to add about myocarditis?
Viruses, you were discussing about the viruses which can cause the myocarditis. Which one is the common one?
Coxsackie is the most common. Then comes the adenovirus and other enteroviruses.
Yeah.
And also
adeno second, Coxsackie first, adeno second, and sometimes parvovirus can be, but it's not very common. These three are the common one you mentioned. Coxsackie is first, second is adeno, third is adeno.
Let's mention the most common Coxsackie.
Yeah, just make it simple for you. Just three, keeping three in the mind. Coxsackie, adeno, and adeno.
Which is this virus? Infectious mononucleose virus. Which one that is?
EBV.
Even it can cause, but rare. So the common
rare. Parvovirus and EBV is less common, but these are the most common. Coxsackie, adeno, and
Coxsackie 1, adeno 2.
Second adeno, third, because I saw one patient, adenoviral myocarditis. 18 months, he was 18 months around the patient. He had adenovirus.
Till what age cardiac patients admitted?
For us? Up to 14.
14. Okay, so you
from 0 to 14, 0 day to 14.
So if you get a cardiac case, it will be like a
not that easy, really. You saw the mock exam. I was more confused in cardiac.
Okay, no problem. Okay, I will just want to ask you. Okay, one of you will tell the signs of cardiac failure. Signs of cardiac failure. Okay, Dr. Adnan will tell because he was the candidate.
What?
Signs of cardiac failure.
Signs of cardiac failure from the hands we can start. There will be cold peripheries and the pulse will be thready pulse or very weak pulse. Blood pressure will be low.
Very good way to start, Dr. Adnan.
Tachycardia.
Very good from the hand. Yeah, very good to start from the head.
Yeah, that's my way to remember.
Yeah, this is very good way, Wallah. Very good. Because
usually
you will forget.
Hand, you said cold peripheries and
there will be cold peripheries or capillary refill time will be decreased.
And
no, capillary refill time will be more. I mean to say,
more than 2
seconds. More than 2 seconds. And in the pulse, there will be a kind of
thready pulse.
Tachycardia, but very weak pulse and thready pulse. Blood pressure will be decreased. And then we will come to the face. There will be a kind of maybe kind of dehydration kind of faces can be there, like sunken eyes can be, not too much, and dry mouth will be there. And in the heart, we will check for the heart sounds. So heart sounds will be muffled, especially there can be S3 or S1, S2 and S3 and S4 gallop rhythm can be there, and muffled heart sounds, and there can be any new murmur associated with that if there is endocarditis.
I think, Dr. Adnan, if you don't mind, can you just after hands you just tell tachypnea, tachycardia? That will be also the good way to start. After you finish with the hand, like cold peripheries, their pulse, then tell tachypnea, tachycardia, because this is the most commonly they will have the signs.
Yes. Tachypnea, tachycardia, I told this one. Then blood pressure, then on the face, there can be dehydrated face can be there because he's in shock. Yeah,
he's in shock, so he will be dehydrated for sure.
Okay.
So in the heart, when you are examining, there will be muffled heart sounds, and gallop rhythm can be there, S1, S2 and S3, S4. What else we can see? Journal examination, liver. You can find a liver also, and if it is,
Hepatomegaly. You can find
yeah,
hepatomegaly.
yeah,
Okay.
hepatomegaly, and even in JVP can be raised, but it depends how much is this heart is like congestive cardiac failure is there. So definitely there will be raised JVP and hepatomegaly and edema in the lower limbs, or pedal edema, or sacral edema sometimes dependent. And in the chest, there will be there can be fine crepitations. So all these are signs of heart failure.
Okay. What about cardiomegaly? When you palpate for the
Yeah,
apex?
yes, cardiomegaly can be there on when
Yeah,
you will
it
check
is
this one
usually,
apex.
yeah, when you check for the apex bit, there can be cardiomegaly finding,
Yes,
like maybe the heart is displaced in sixth intercostal space lateral to
and this will be, I think, will be ill
You can
sustained.
say in the heaving pericardium,
hyperdynamic
prominent
apex.
pericardium, hyperdynamic
I
pericardium, and
have written the
heaving.
points, but this is from Mark. Okay.
Yeah, hyperdynamic
What Dr. Adnan
pericardium.
said is going with congestive cardiac failure. Sorry,
Yes,
Yes, this
yes,
one.
yes.
cardiogenic shock and cardiogenic shock also. Okay.
Yes,
When
yes.
there is just failure, not failure, not still not in shock, you will not see all these things. Like you may have tachycardia, but not that much weak and thready pulse and cold peripheries. Okay. This is more for cardiogenic shock, but only for the failure. Main things you see is the tachycardia and
Yeah,
shortness
that
of
one is
breath.
different. Yeah.
Yeah, what you said is also good. It is the signs of cardiogenic shock. Okay. Now for shock associated with cardiac failure. Now for the only for the heart failure, tachycardia, shortness of breath. In the heart only, if I have to say, tachycardia, cardiomegaly, hyperdynamic apex, and gallop rhythm. Okay.
Galopin.
This is for the
Yeah.
heart. For the lungs, you will have shortness of breath and basal crepitations.
Yes.
For the abdomen, you will have hepatomegaly. And for the peripheries, you will have sacral and peripheral edema. Overall, the child who will have heart failure for a long time, he will be faltering growth. Okay.
Yes.
This is the overall for heart failure. But what you said for cardiogenic shock along with it, it is good. Okay. Now, I want to know about this S3 and S4. I don't know. I know only that S3 you can hear like a horse galloping. What about S4?
S4, I am not getting. What do you want? S4 is also a sound. It's coming in, especially in failures, and if a
S4
child
is
is in
also
guard.
called as gallop rhythm. It will come in that.
Yes, yes.
Okay. Yeah, Dr. Yasser, you know anything you want to add here, or Rehana?
Gallop is a sum of S3 and S4.
Yes, some of this one.
Okay, this I didn't know. Thank you. Okay, tell still if you know any more.
Like which I remember.
Difficult to memorize.
Yeah, which I remember. This one S4 is S3 and S4 is coming. This is sum of gallop rhythm, and if there is any ischemia is going on, or any dilate this
Inflammation. Like
Yeah, it's
diastolic function.
as Dr. Yas says, between the this one S3 and S4 is it's like in the late diastole. If you have
Yes,
late diastole, it will be S4. You will hear the S4. Your heart is relaxing like very late. Diastole is happening very late, and you will hear this sound. That's the time only you will hear this sound.
both.
Like
like
Dr. Yas said.
if they have
S4
lost
comes in.
diastolic function, so this will
If you
come
have
S4.
if you have like function of the heart is depressed, especially if diastolic dysfunction, so that time you will hear this S4.
Okay, that means the heart is relaxing for a long time. Means it is in diastole for a
Yeah,
long
it is getting late to relax the heart. Diastolic, if your heart is not having diastolic phase as normal, it takes time to relax. That time you will hear this sound.
So even
late diastole.
so it can come in any heart failure case. Here
It can
is
come in the
myocarditis.
heart, but especially if you have like depressed function, and they have cardiac failure. In those cases, you would get.
Okay. And in the pericarditis there will be ST segment elevation, right? In the
Yeah. Also, as Dr. Adnan said, you will hear the muffled sound in pericarditis.
It's
Inverted P sounds and muffled heart sound. This is they are specific for the pericarditis.
What's Dr. Rihanna? What is in the BP in pericarditis?
BP. I forgot the BP.
Maybe
Narrow complex or wide complex? The narrow pulse pressure or wide pulse pressure?
It will not be the
pulsus paradoxus, I think.
No.
I forgot.
But yeah, that's a character of the pulse. Na?
Narrow.
Because the heart is unable to diastole. Na? So that's the reason.
Okay. So I think we will go to the next case. So we should know this, these signs of heart failure, you know it, so that it is good. Okay, our next case is Dr. Yasser will give, okay?
I send you WhatsApp. Can you share the pictures?
Sure. So you want to share all these three pictures, right?
Yes.
Okay. You can start now. Okay. 3-year-old.
Yeah, 9-year-old John presented with fever and shortness of breath. Do cardiovascular examination at the relevant.
Okay. So keep time 3 minutes from now. Okay.
Okay.
Okay. Good morning.
Good morning.
This is Dr. Noor, one of the children's doctor in this hospital. I am here to examine John. I will take permission from his mother and wash my hands and start examining John. I'll just talk to him. John, how are you? To see whether he's well communicating or not. And also at the same time, I'll look for any distress. Is he well looking, not in distress? And also would like to check his weight, height, and the plot on the appropriate growth chart.
He's in respiratory distress.
Okay, otherwise he's fine. Then I want to check for any unusual features in his face, and is he attached to any cardiorespiratory monitoring or any devices?
Yeah, he is attachable, having a heart rate 150 per minute and a respiratory rate showing in that one it's 30 per minute, and saturation is 92%.
Okay, and anything in the surroundings, I will check for it.
Attach oxygen.
Okay, oxygen. Now I will examine his, I will go to examine his hands for pallor, jaundice, cyanosis, clubbing, and signs of infective endocarditis like sphincter hemorrhage, Janeway's lesions, and Osler's nodes.
He is pale, palms are pale and cold.
Pale and cold. Okay. Then I will go for checking his pulse to look for rate, rhythm, character, volume, and also at the same time I will check the other radial pulse to see any radio-radial delay, and also the femoral pulse with the radial pulse to check any radio-femoral delay.
Rate is 154 and volume is low, and others are characters are normal.
Okay, no radio-femoral and radio-radial delay. Then I would like to check for the water hammer pulse. I will raise his hands, keeping my hand on the forearm.
Yeah, there is water hammer pulse positive.
Okay. Then BP I will check on the end. I will go for the face to look for pallor in the eyes and any jaundice.
He's pale.
Pale. Okay, I would like to examine his mouth for any central cyanosis, dentition, and any high arch palate.
No, dentition is quick and hygiene is okay.
Okay. Then I would like to look at the neck for any visible pulsations.
No.
No visible pulsation. Then I will keep him, I will rest him at 45° and wants to check for the any deformities, any scars, any visible pulsations over the chest. And also, since he is in distress, I want to check for suprasternal, intercostal, and subcostal retractions.
Yeah, his left sided chest is bulged and respiratory rate is 30 per minute, and there is a subcostal recession.
Okay. Then I will put both my hands on the chest to look for the apex beat.
Okay,
Where
apex
it is
is
localized.
apex in the sixth intercostal space lateral to the mid clavicular line.
Okay, then I will check, put my heel of the hand or the left lower part of the sternum to check for the parasternal heave.
Yeah, there is no heave.
Okay, then I will check all the 4 areas of the mitral, tricuspid, aortic, and pulmonary to see for any thrill and also palpable heart sounds.
Thrill is palpable in the apical area and others are normal. No other palpable heart sound.
Okay, then I want to auscultate for heart sounds S1, S2 with murmurs and any radiation of murmurs in all the 4 areas, that is mitral, tricuspid, aortic, and pulmonary.
There is a pansystolic murmur in the apical area that radiates to axilla.
Okay, radiating to axilla. Now I want to auscultate his chest if there are any basal crepitations, and also want to palpate his abdomen for hepatomegaly and lower limb for edema.
Yeah, he has a crepitation in the chest and he has 3 centimeter tender liver, and there is no edema.
Okay, from the universal Q, I want to describe also he has some skin rashes in the form of erythema marginatum that is clear in the center with redness in the margins, and also he has some subcutaneous nodules in the elbow. Okay. Yeah. So in order to complete my examination, I want to take a detailed history, check his complete vital signs, including 4-limb blood pressure and 4-limb oxygen saturation, and stabilize the patient since he is in distress. And then I want to
finish
JVP and Tanner staging.
Okay.
Okay, plot him on the appropriate growth chart for age and sex. So today I examined John. He's a 9 years old child. He is in distress with RR of 30, and he has a slow. He has pallor and he has a slow pulse, which low volume pulse, which is 154 per minute, and he has water hammer pulse positive with. He is pale and there is left-sided bulging on his chest with no visible pulsations. His apex beat is palpable in 6th intercostal space lateral to mid-clavicular line, and he has a thrill in the apical area and a pansystolic murmur in the apical area radiating to axilla, and he has an hepatomegaly 3 centimeters palpable, which is tender, and basal crepitations and mild edema in the lower limbs. With these findings, this child most probably has fever, shortness of breath, and features of heart failure with some signs of rheumatic fever going with him. So my first differential diagnosis will be rheumatic fever in this case.
What could be the other differentials?
could be myocarditis,
Okay.
congestive heart failure, or some congenital cardiac disease causing the heart failure,
Like
VSD.
okay. So how will you manage?
This patient, since this patient is in distress, I will check his airway, breathing, circulation, check his vital signs, give him oxygen, stabilize the patient, and then I want to send some lab tests for him like CBC, CRP, ESR, and do the ECG, chest X-ray, and echocardiography for him.
What you want to see in ECG?
ECG, I can see PR, prolonged PR interval.
Okay. What you see in CPC?
CBC, if there is signs of infection, there can be mild leukocytosis. And also, since he is pale, there can be low hemoglobin. And ESR and CRP can be elevated.
Okay. Next, proceed further.
I want to, if the child is in since the child is in heart failure, I want to start him on the failure medications like diuretics and the heart failure, and I want to involve my consultant and the cardiologist.
Okay. Anything else?
He
okay,
needs
time finished.
Okay.
I'm already finished. Okay. Anything else?
Yeah, we did CBC, CRP, ECG, chest X-ray, echo. And I want to do complete examination for him to see the other things like arthritis, other features like arthritis.
Anything else?
I'm missing anything important. The treatment, yeah, treatment is since he has features of rheumatic fever, to diagnose, I want to check for the stigmata for infection of streptococcus, any source of infection for streptococcus. So I will do ASO titer for him and anti-DNase B, and also antibodies against streptococcus will be done, and throat culture for streptococcus. And I will start him on the antibiotics, that is penicillin, for 10 days. And for eradication of infection, these patients should be continued on benzathine penicillin monthly to prevent for eradication, and for the to prevent the recurrence of rheumatic fever. We have to continue them on monthly injections of benzathine penicillin. For
how long?
If for 10 years, for 10 years or 21 years, which one comes earlier, but there is 3 criteria here. If the child has carditis like this patient, he should be for 10 years and 21 years. Yes.
Okay. Okay. Your approach is good. Only things you miss, chorea for hand movements, you did not mention. Okay. And throat swab you mentioned at the end, but it should be ideally first test you have to advise. And dietitian you did not mention.
Yeah, multidisciplinary team, what will come apart from pediatrician and cardiologist? Dietitian
and intensivist. Maybe this patient need, because he's in failure distress needing oxygen, so he need intensivist for pediatric ICU, pediatric
intensivist. And as you have seen their dermatologist definitely will have to take opinion, and rheumatologist have to take opinion.
Rheumatologist, what he will do for this erythema marginatum? It is
they are not doing, just you will have to take opinion. I told they are not doing anything, but
okay, are they referring to rheumatologist, these patients?
If arthritis is there, you will have to take one opinion.
Okay, why orthopedics or rheumatologist?
I think they are sending rheumatologist. These are all just opinions they are taking, which I remember. I don't know. Dr.
Opinion.
Yasser is working there. Dr. Yasser, you can tell.
No, I don't think so, because it's only cardiac, because there is no treatment for, because this is acute rheumatic fever, and as we give
Okay,
aspirin
and
and
also I have to tell for this NSAIDs for the arthritis
Yeah,
is given.
answered you will have to tell. And one more thing, which yeah, you will have to give the advice to the
parents
Parents,
parent advice, bed
parents,
rest
about,
complete.
especially for the if the child is having any major surgery or having any dental surgery, so they should tell to the doctors about this rheumatic fever. And also for the proper dental hygiene, even though they are not giving for any prophylaxis, but even
yeah,
though
you
you
have
should tell.
to, yeah, and also the main treatment I forgot to tell you, bed rest.
Yeah, bed rest is very important.
Yeah, I forgot. Bed rest is important, and also what is important here, and also to limit the activities later also till they are fine. The activities has to
Yeah,
be limited. And
activities
for
have to be
this question of yours, like benzathine penicillin, I think if there is rheumatic fever without carditis, they are just giving for 5 years. If there is carditis, for 10 years. If there is carditis and valvular involvement later, it will be long, like 40 years.
Actually, they have to see. They are saying if it is simple rheumatic fever without carditis, means arthritis and other fever and other, so they give 5 year and 21 year. If
Yeah.
there is, and then they will evaluate at 3 months. If there is residual, then you can go for 10 years. If there is no residual, only 5 year as before. But if there is any residual, and
Residual on a what? Some features of carditis, you mean?
yeah, he has suppose arthritis, so he needs 5 year and 20. If there is residual, 10 years, and if then they will follow. And if there are I mean residual, they're 10 year, and maybe if they need another, they have to need long life.
So this one is 21 years age or 21 years plus the presentation
Age.
Yes. I
Yeah,
think there
age.
was one criteria also that was giving for long life, which I
Yeah, I
remember.
forgot, because there are three
No,
scenarios.
I will tell you. Today I read. So first thing now, for example, this case is clear. He is rheumatic fever with carditis. Okay, this case. So for him, I will go for 10 years. Now, there is a rheumatic fever with no carditis, like he has other features, arthritis, chorea or anything, but he has no carditis. You will just give for 5 years or 5 years from now or 21 years, which one ever is comes longer, which one ever is longer. Okay, suppose the child is 20, suppose the child is 18 years old. You will give him for 5 years. Suppose the child is 10 years old, you will continue till 21 years. You got my point? Whichever is longer, you have to tell. Okay, this is first. Suppose you have rheumatic fever plus carditis, like our case. 10 years, you have to give for 10 years or to up to the age of 21 years, whichever is longer. Okay. Suppose some cases have, now his carditis, maybe he can improve completely without valvular disease. For him, you are giving 10 years. But there are some cases who will have carditis and at a later stage, they will develop valvular disease. For these, you are giving long. There is like 10 up to the 40 years of age. They have written 10 to 40 years. Okay. So up to 40 years of age, you can continue. And in severe cases, it can be lifelong. In means the more severe damage and valvular replacement, in these cases, it can be lifelong. Okay.
And it means those who develop rheumatic heart disease, they have to go 10 to 40 years.
Yes. Means if there is valvular involvement, mostly up to 40 years of age, this is the final. Up to their age is 40 years. Okay. And if there is still means when you replace the valve, when it is damaged too much, right?
What are the indication for surgery? Sorry, this question left.
Yeah, indications for surgery is the severity of valvular damage and persistent heart failure due to mitral
Despite
regurgitation.
not responding to medication.
Yeah, not responding to medical management.
Number one. Number two is dyspnea with moderate restricted activity. And third is cardiomegaly with pulmonary hypertension. These are the valvular anoplasty. And what are the for valve surgery? Valve replacement, indication.
Fibrosed valves.
Yeah, number one, yeah, fibrosed valve. And severe mitral valve damage.
Okay, I will write it in my notes. Wait, tell me, wait. Okay, I will write here and later I will write. Can you again tell me the indications of surgery?
First is that is anoplasty, na? That means
what? Valvuloplasty. Indications for valvuloplasty.
Yeah, actually, but that is means recurrent heart failure despite medication, persistent heart failure despite medication.
Okay.
Then dyspnea with moderate activity.
Is okay.
And then progressive cardiomegaly along with pulmonary hypertension.
Okay, means you cannot control all these things with medication. This is one of the main thing here. Okay, this is for the valvuloplasty. Then to do valve replacement. Fibrosed valves, I said. What else?
Severe mitral valve damage.
Okay. Okay. Anything else? That's all, sir. We finished all discussion.
And pericarditis could be one of the differential in any one of them.
Yeah, what differential? You asked me for rheumatic. I told rheumatic fever, congestive cardiac failure, and also the congenital heart disease leading to cardiac failure. What else I can give my differentials? Myocarditis also.
Yeah. You can keep myocarditis, pericarditis also.
Okay, so this much. But
in pericarditis, there will be finding on the chest as well.
Like
there can be sounds are coming of rubbing sounds.
Yes, if I put the stethoscope, there will be rubbing sound. Yes.
Pericardial rub.
Pericardial rub. Yes.
Okay. So what you have time now, Dr.
Yeah, no problem. We will finish today. No problem. 10 minutes. I will go late. Dr. Yasser, if you have for this rheumatic fever good notes or anything, please share in the group. Anything from anywhere.
Yeah, I have also made good notes, but these are the extra points what Dr. Yasser said. It was not there in my notes. I added.
Yeah, you can share with me because I have sent each and everything home. I don't have too much now. I have only 2 or 3 my books only.
Yeah, this is I shared it the book. This Muntasir. It's very good. It's page 146. It's written very good there.
You read from Muntasir, this one, Dr.
Yeah.
Okay, yeah. Muntasir book is very good and he gives good pictures also. I know that.
You share in the group already?
Yeah. The one I put it, Dr. Rehana.
Dr. Noor, you also share if you can your notes.
I will share after this, after the class. Okay. Now let's go.
Yasser,
you have any picture? Give me first.
Yesterday I save. I don't know. Just 1 minute. Okay, we'll write it.
Yeah.
I will keep the time now. 6 minutes, right? I will keep the time.
Yes.
You can start.
Okay. You can start now.
Yeah. Good evening. My name is Dr. Yasir. I'm the treating physician for today. How are you, John? Are you fine?
fine.
Okay. I want to see the surrounding area, any oxygen mask, any nebulization machine, any cardiac monitor, any
No,
aid.
there is nothing in the surrounding.
Okay, I want to see any inspect the child, any he's in distress,
No, not in distress.
he's well looking or ill looking,
Well looking.
well looking. Okay, I want to check his height and weight, and also see his growth chart if available.
Well grown.
Well grown. Okay, I want to see his
Continue.
any
I
dysmorphism.
will tell you where is the finding. Continue.
Okay, then I will start examining the examination. From the hand, I want to see any cyanosis, any clumping, any pallor, any side of infective endocarditis in the form of splinter node, splinter hemorrhage, ocular node, and JNV lesion. Then I will examine
No,
the pulse.
nothing.
Uh,
Yes.
Okay, I will examine the pulse. I will take the rate. I will check the rhythm. I will check the
Normal
compare the
volume pulse 90 per minute.
90 per minute. I want to check his collapsing nature or not, and then I will compare with the other radial nerve, radial pulse, and also check radiofemoral delay.
No.
Okay, I will take PP at the end.
Okay.
I will go to the eyes. I will want to see any jaundice, any pallor. I want
No
to see
jaundice, no pallor.
I want to see the oral cavity for dentition, oral hygiene, any cyanosis on the lips.
No, dental hygiene is a little bit poor. Otherwise, no deformity is there, no cyanosis.
Okay, I want to see the neck for JVP.
Normal.
Any visible pulsation in the neck?
No.
Okay, I want to check the symmetry of the chest. Any scar mark?
Yeah, normal. No. Yes, there is scar mark you can see in the picture.
Yeah. Okay. Any visible pulsations?
No.
Okay. I want to check the apex beat.
Okay.
And
Apex is in the fifth intercostal space, mid clavicular line.
Mid clavicular. I want to check the character of the apex beat.
Okay. Next.
Next, I want to see any visible pulsation. I want to palpate first heart sound and the second heart sound in the pulmonary area.
Where else?
I want to check the left parasternal heave in the epigastric area and also in the left.
No thrill, no. Yes. No parasternal heave.
Okay, I want to see any thrill, any palpable murmur.
No.
Okay, I want to auscultate the heart in the apical area. I want to auscultate first heart sound.
Okay,
And
you can appreciate where you want to see.
First, in the apical area, I want to see the S1, and I want to see S2 in the pulmonary area.
What else?
Then I want to auscultate for the murmurs in the apical area, tricuspid area, pulmonary area, and aortic area.
In the aortic area, there is a click.
Okay.
This is coming in the third intercostal space.
Sorry, again, in the?
Almost third intercostal space. Nearby.
Right or left?
Right side.
Right side. Okay. Right side. Okay. Then is there any radiation?
No, there is click only.
Only click. Okay. Then I want to examine the back to see any scar mark. I want to see any auscultate the heart lungs to see any crepitation.
No crepitation.
Okay, and then I want to see the back for also the any sacral edema. I want to see the abdomen.
Nothing.
For
The
hepatomegaly.
abdomen, what do you want to see?
For hepatomegaly, for to see the failure, and spleen for infective endocarditis.
No.
Okay, I want to see the peripheries, the lower limb, to see the edema, pedal edema.
No.
Okay, and then I want to see the, I will do offer 4-limb blood pressure, and I want to see
Time
any
finish, 3
pulse
minutes.
oximetry,
Okay.
and then I want to plot on the centile charts for his growth and weight to see if he is appropriate for his age or not.
Okay.
Okay, I have examined 4-year-old boy who's having a mid sternotomy scar, and he's not in respiratory distress, and he has no dysmorphism. He has heart rate of pulse of 90 beats per minute regular, and there is no sign of cyanosis and infective enditis periphery, and he has poor oral dental hygiene. On examination of the precordium, apex pit is in the 5th intercostal space of normal character, and there is no first and second heart sound are audible of normal character, and there is only click is auscultate only in the right aortic area.
Okay.
The patient is currently not in failure, and there is no other sign of infective endocarditis.
So what will be your differential?
My differential could be a case of repaired aortic stenosis.
Okay. Repaired, and repaired with what?
With prosthetic with prosthetic valve.
Okay, good. So what kind of prosthetic valves are available?
There are 3 types of the prosthetic valve. Number 1 is a material. Other one is animal origin, and third is donor type.
Third is donor. First is material.
Metallic material.
Metallic.
Yeah.
Metallic material. Okay. And what do you think? What is this? Which one? This one?
It is look like metallic.
Okay, good. So what prophylaxis child needs if metallic has been used for
they
the
need anticoagulation
anticoagulation for
to develop this thrombosis.
Yeah, for
thromboembolic, to prevent thromboembolic events.
To prevent thromboembolic event. For how many years he want?
Whole of the, if it is whole of the life.
Okay, for porcine?
10 years.
Okay, for donor?
Donor, sorry, I cannot get information. Donor, there is no need.
No need, yes. Okay, so what advice you will give the mother?
I will inform her that avoid the strenuous exercise. Second, whenever he has any dental procedure, he has to inform the doctor regarding his metallic valve. If he needs prophylaxis before any surgery and before any extensive dental procedure. And third was
yes, good.
Sorry, third I forgot.
So he needs prophylaxis. Very good. So what else? So this is metallic is bidirectional or unidirectional?
Bidirectional.
Okay. And if it is bidirectional, there can be a chance of
Regurgitation.
regurgitation. Yes.
Yeah, yeah.
There are available unidirectional also. Yes.
Yes, yes.
So specifically in which they are using this unidirectional. This one I also don't know, but I am asking you.
I know. I have no idea.
I searched this one for I don't know. Okay. Finish. That's good. Just you needs Dr. Yasser. That was very good. You cover each and everything almost. But when you are starting, like you have introduced yourself, just you forget to wash your hands. So just if you make a template, that will be good. So I will introduce myself and take permission and wash my hands and just make a build a repo or make a repo, put him at ease and uh, well communicating or not. Just we'll check well communicating or not. Then we'll see in the surroundings or in the child face. So these few things in the beginning you are forgetting, and when you are describing, so always start from the hand. So my cardiovascular, I have done cardiovascular examination from the hands. There was no clubbing, cyanosis, and no stigmata of chronic liver disease. Sorry, infective endocarditis, and the pulse rate was that, and there is no cyanosis, central cyanosis. Chest on the chest, my local examination. This is journal. So my local examination, there is no visible pulsation, and the apex is in this fifth intercostal space. And on my palpation, there was no finding like thrill or parasternal heave, and on auscultation, my these findings like this. So this will be a good. Where you start from, there you will describe. Okay, that was fine.
Yeah, but I think your presentation was it was more than 1 minute. I was seeing here because I was.
Yeah, that one more than 1 minute was because he
I
started. Yeah, he started giving findings first, then he start again from the hands, then again went to the. So
yeah,
that's
yeah.
why it was.
Just practice in home for 1 minute. This is happening with me also, but we have to practice. And one more thing, they say that since you are talking to the examiner and examiner knows all this what happened, sometimes you can summarize within 1 minute, because 3 minutes there is marks for you for investigations and management, right? If we don't cover up investigations and management, our marks will be cut, will be undermarked, because for the segment of investigations and management, they cannot give marks if we don't cover up. So we have to make our summary very short and sweet. And so what I suggest you is just positive points. Like today I examined 14 years old John. For the infective endocarditis and heart failure, we can tell it at last, like no stigmata of infective endocarditis and heart failure together.
Yes.
Okay, so just you can say that he has pallor, if he has pallor. Okay, he has pallor and he has a central sternotomy. On examination of the cardiovascular system, the positive points I got are he has a central sternotomy scar, and there is a click in the aortic area. There is a click heard in the aortic area. Okay, with no stigmata of infective endocarditis and no stigmata of heart failure. Because all the questions you asked, you are asking with the examiner, right? You can make it very, because in this case there are no much findings. Like in my last case, I think I had pulmonary murmur radiating to axilla, all those things I have to add. But what Dr. Adnan is telling is also right. When we go, we can start as today I examined John. Suppose now what is there is respiratory distress in my case, right? So he was in respiratory distress with RR of 30 per minute. This is positive point, I will tell. And what is the heart rate? 120 per minute or 150 per minute. There is tachycardia. This is positive point, I will tell. And I will tell that he has pallor or jaundice. This is finished in the hand. And then I will go for the face, poor dentition. This is positive point. And in the chest, there is a thrill in the mitral area and palpable, thrill in the mitral area and murmur in the mitral area, which is pansystolic, radiating to axilla. Okay, with no stigmata. Finally, I will tell these 2 points together. With no stigmata of infective endocarditis and heart failure. In my case, there was heart failure. I should tell everything, apex beat, everything I have to tell. And finally, when you are telling, I think there is one of our teachers who always teaches that when we are telling, just don't tell the diagnosis directly. Say like this: it is a complex congenital heart disease, post-operative, with a click in the aortic area. Okay, it is a case of complex congenital heart disease, operated, or you can say post-operative, with a click in the aortic area, with no signs of infective endocarditis and heart failure. So most probably this is an aortic valve replacement. Okay.
So one more thing I will tell when I ask you what you give the advice to the mother or the patient. So always tell that I will give the advice as the child is having, which I'm thinking, prosthetic heart valve. So it should be prophylaxis for the endocarditis. How you can prevent? First is dental hygiene and care. If the child is having any major big surgery like gastrointestinal or genitourinary surgeries, he should tell to the doctor. He should avoid tattoos, body piercing, IV drug use. Okay, all these should be tell. These all.
You're right. And nowadays for this, we will read this through later through the guidelines for all these, like endoscopy and all this is not needed unless there is suspicion of infection in those areas. Okay, but for major surgeries, which will be open surgeries, we have to give the prophylaxis, right, Dr. Adnan?
Yes.
If you're doing like open laparotomy or open heart surgery or any surgeries, you have to give the prophylaxis. But if it is like bronchoscopy, endoscopy, and you know that you're not suspecting any infection in this area, you can do it without prophylaxis. But if there is suspicion of infection, at that time you have to give the prophylaxis. Okay.
Yes, prophylaxis, for the dental hygiene, if they will ask you twice a day, should we brush, and every 6 months should we check with your dentist. Okay, completely avoid for the tattoos or body piercing, IV drug users, that should be avoided. Okay, this one all should be tell. Proper good oral hygiene.
Yeah, always whenever there is an operated case, we will always start like this: complex congenital heart disease, post-operative. Suppose if this child had cyanosis, then you will say complex cyanotic heart disease, and if whether it is post-operative or not, depending upon the scar. Okay, if there is scar, you will say post-operative. If not, you will say not say it. Okay, the practice like this, start with this and then you come to the diagnosis. Okay.
And if they will ask you, as you told about the anticoagulation like warfarin you are giving, so INR will be, target value will be 2.5 to 3, which now I remember yesterday I studied this one.
Nowadays enoxaparin is ongoing.
What they are giving?
This low molecular weight heparin.
Okay, that's great also.
Okay, so if for warfarin, INR should be maintained 2.5 to 3.
Yes.
Okay, and they are giving anticoagulants only with the mechanical valves, not with the animal and donor, right?
No, for metallic, they are giving long life. And for porcine like animals, they are giving for 10 years. And the Dr. Yasser rightly said. And for this one, donors, they are not giving, but donors, I don't think so. It will be available easily.
No,
so just tell about
anticoagulation only for 10 years?
10 years for the animals, if the material has been used from the animal. There are two types. like avoid from donors. I will not tell about the donors. There are two types. Metallic prosthetic valve is available, and one is available from the animals they are taking.
Okay.
This is from like porcine pork. Usually they are using pork mostly.
Okay.
So for that, anticoagulation will be given 10 years. And if it is used metallic, for that will be given for whole life. And one more thing, I think click is coming only in the metallic.
Yeah,
In
click is coming
the in the animals, it is not coming. Yes, Dr. Yasser?
Yeah, but Dr. Adnan, I don't know, this you read from where? Here in the Khidar's book, it's given that for tissue, like animal tissue, no anticoagulation, but I'm not sure. You read from some other source?
Maybe. Dr. Yasser, from where you read?
From where, Doctor? Noor read.
No, Dr. Noor is saying that there is no anticoagulation.
I will
Because
share.
I was thinking its life is 10 years. So maybe I did not focus the anticoagulation, only metallic I focus.
Okay. Yeah. You are right.
You people are,
His
wait,
life
wait,
is 10 years.
the picture, wait.
Yeah. No, Dr. Noor, you are right.
Yeah, I am now confused. Wait.
No, you are right.
So I read from this paper, okay, what he is telling you here.
No, you are right.
Here he is telling mechanical, synthetic material lasts more than 20 years, need anticoagulation and click. He has not given any time here, just written needs. And this valve will stay for 20 years. This is what he is telling. Maybe after 20 years, it may need replacement. Okay. And here he is telling animal tissue and it will last for 8 to 10 years. Less, the life is less here. And it requires no anticoagulation and no click. So anticoagulation is only for synthetic material according to here, but I don't know. I did not check anywhere else.
No, this is synthetic metallic material. This is also coming in different shapes, but we don't need to remember that. Yeah, this is right. He has written right. Hither has written right this one. Yes.
Okay, and will they ask about pacemaker? These valves will cause arrhythmias, right?
Yes, it can cause arrhythmias. This
Here
is not pacemaker. Pacemaker is another that will become on either on the chest on the left side. There will be shape if you can check on the Google, or it can be pacemaker in the epigastric areas.
Okay. No, I am telling you, as he has mentioned here, pacemaker, because the side effect of valve replacement can be arrhythmias. Here he has written.
Arrhythmias can be there with this prosthetic valve. Arrhythmias can be there.
Yeah, recurrent bradycardia and tachycardia syndromes is a complication of post-surgery. It's written here, you see.
These are the indication for pacemaker.
No,
these are the indication of pacemaker, Dr. Noor.
Okay, yeah, that's what. Now for this.
Ideally, this is a separate topic.
Okay, it's a separate topic, but I'm connecting this here because post-surgery, these children can have this bradycardia and tachycardia. Maybe they can use pacemakers here also. This is what I'm telling.
Okay.
Okay, if you think more about prosthetic valves, please post, both of you, because I did not get any good information anywhere. Okay.
That is good.
Okay, we are done.
Tomorrow we will do what?
Record. So in endocarditis prophylaxis, what happens? Patients at risk of infective endocarditis. So who are the patients? Acquired valvular heart disease with stenosis or regurgitation, hypertrophic cardiomyopathy, previous infective endocarditis, or structural congenital heart diseases, including surgically connected palliated structural conditions, but excluding isolated atrial septal defect, fully repaired ventricular septal defect, and fully repaired PDA and closure devices judged to be endothelialized and valve replacement. So the main thing we have to remember is any acquired heart disease like rheumatic heart disease, the most commonest with stenosis and regurgitation, hypertrophic cardiomyopathy, previous history of endocarditis, and valve replacement. For the structural congenital heart disease, any which is surgically connected or palliative, except atrial septal defect, ventricular septal defect, and PDA, which are fully repaired. Okay, and also if there is endothelialization of closure device. So what is the advice? This advice we will, when it is asked in the exam, we will tell for all the CVS cases who are prone for infective endocarditis. So provide explanation of why antibiotic prophylaxis not routinely recommended. Importance of maintaining good oral health. So we have to explain the parents always to give good oral hygiene. Symptoms may indicate infective endocarditis or when to seek expert advice. So we will always tell the mother whenever the child has high grade fever, infection, she has to come to the
Emergency.
doctors. She has to come to they have to approach to the doctors, because if there are any features of infective endocarditis, they can work it on that. So symptoms that may indicate IE and when to seek expert advice. Risk of undergoing invasive procedures, including non-medical procedures like body piercing and tattooing. Just now Dr. Adnan was telling this. We have to tell them that there is a risk of infective endocarditis if they do this body piercing, tattooing, and also what else he told? He told one more point. I think IV drug abuse. IV drug abuse for the teenagers. You have to advise them. It can cause endocarditis. So prophylaxis against infective endocarditis is not recommended routinely. So if they ask, we have to be very clear, not recommended routinely for children undergoing dental procedure. No need. Do not offer chlorhexidine mouthwashes prophylaxis. If any child undergoing dental procedure, no need for routinely. Non-dental procedure at following sites: upper and lower gastrointestinal tract, genitourinary tract, upper and lower respiratory tract, including ENT procedures like bronchoscopy. So no need for endoscopy, and also cystoscopy and bronchoscopy and all these procedures, no need. Infection: to reduce the risk, investigate and treat promptly any episode of infection in child at risk of IE. That is why we have to advise the parents that any time the child has infection, they have to approach the doctor so that he can be evaluated to check for the features of infective endocarditis. So if at risk of IE and receiving antibiotic for gastrointestinal genitourinary procedure at a site with suspected infection, give antibiotic that covers organism that cause IE. So you will give only if normally for the gastrointestinal and genitourinary tract procedures you will not give. But if there is suspected infection at these sites, then you will give the antibiotics. This is how I remember, right? It will be easy. If uncertain,
it means any invasive procedure, if there is need, then we can go. Otherwise, just like this endoscopy, cystoscopy, they are non-invasive, means no need to piercing the skin or just like this one. Na?
Yeah, you're right. So always remember invasive procedures, even simple like body piercing, like piercing the ear, tattooing, and IV, and if they do IV drug abuse, all this is the risk. But if it is non-invasive, just cystoscopy, endoscopy, no need. But if you're suspecting infection, you're doing some cystoscopy and the child has infection, you're suspecting, then you will give. Okay, this is what is the new guidelines. And then the next. So for heart failure, since we did many cases which are related to heart failure, like today's myocarditis and rheumatic heart fever, and also yesterday Eisenmenger and VSD, all this is related to heart failure, right? So we should know the proper management. So let's see from the guidelines. So heart failure and weak pulses, causes congenital heart malformations, aortic stenosis, coarctation of aorta, hypoplastic left heart. So this is during the birth, critical aortic stenosis, coarctation of aorta, hypoplastic left heart. Then even the cardiomyopathies, pericardial effusion, myocarditis, arrhythmias, hypoxia, hypovolemia, acidosis, and toxins. Okay, so myocarditis came, which we did, and cardiomyopathies, and even arrhythmias, hypoxia, hypovolemia, acidosis, and toxins. So let's go. So how do you recognize? In small children, usually during first few weeks of life, later triggered by an intercurrent infection with associated myocarditis or prolonged arrhythmia. So usually what happens, this critical aortic stenosis, coarctation of aorta, all this will present in first few weeks of life. But this one, intercurrent infection, like our case today, myocarditis, okay, you can have, and also prolonged arrhythmia can cause heart failure. Next is the symptoms and signs. Failure to thrive, rapid weight gain, sweating, breathlessness, particularly during feeding, tachypnea, tachycardia, absent or low volume peripheral pulses or central pulses, enlarged heart, prominent cardiac impulses. That is, we can see hyperdynamic apex. Prominent cardiac impulses means hyperdynamic apex. Quiet heart sounds in pericardial effusion, muffled heart sounds. You can have a thrill, you can have gallop rhythm, and enlarged liver. Okay, all these signs we discussed. Then recognition of cardiogenic shock. How do you know? For definition of shock, see sepsis guideline. So cardiogenic shock should be considered when septic shock fails to improve after adequate fluid replacement. So there is a shock, you are giving adequate, maybe I think 2 boluses is given, 40 ml per kg means each bolus 20 ml per kg, 2 boluses given. You have given more than 40 ml kg and the shock is not improving. So when septic shock fails to improve after adequate replacement, you can think cardiogenic shock. Okay, in a patient with known heart condition, in presence of large heart on chest X-ray, shock with a history of poisoning, where there is murmur and pulmonary edema or both. See, when you give fluids and the septic shock is not improving, and there are other features like the child has heart condition, cardiomegaly, and there is a murmur and pulmonary edema or both. Okay, so investigations, check BP in upper and lower limbs. Normal less than 15 mm of Hg. This is for coarctation of aorta if you suspect for the difference. Then SpO2, check pre and post ductal. Right arm is pre and post ductal is the lower limbs in air and after giving oxygen. Chest X-ray for cardiac conditions, specifically record cardiac situs, whether it is normal or right side, aortic arch, left or right sided, bronchial situs, is it right main, is the right main bronchus on the right, cardiac size and configuration, size of pulmonary vessels and pulmonary vascular markings. So this is mainly in the babies. When you do, you will check for the any right side of the heart. Arch also, 3 things you have to check, whether it is on the right or the left: cardiac, aortic arch, and bronchial situs. Then cardiomegaly and configuration and pulmonary vessels. Is there oligemia or increased pulmonary vascular markings, that is pulmonary edema? Electrocardiogram, see in ECG interpretation guideline. Echocardiogram locally if available, refer to local pediatric cardiac center. Okay, if you don't have echocardiogram, you will refer to the cardiac center. So monitoring, what monitoring we have to do? ECG, BP, pulse oximeter, core skin temperature difference, daily weights, urine output should be more than 1 ml per kg per hour. Means suppose if our baby is 3 kg, it should be at least 3 ml per hour. It should be more than 1 ml per kg per hour. If shocked or more than 40 ml per kg fluid resuscitation, intra-arterial BP monitoring and central venous pressure. Already you have given more than 40 ml per kg of fluid resuscitation and the baby is in shock. You will do central venous pressure and intra-arterial BP monitoring. Then what do we do for therapeutic measures? In all children with heart failure, if breathless, elevate head and trunk. So this is very important. If breathless, we will keep them in sitting position. Elevate head and trunk. If infant not feeding well, give nasogastric tubes. In moderate to severe failure, or if patient is hypoxic or distressed, prescribe oxygen therapy via nasal cannula or face mask. So if the child is distressed, you will give oxygen therapy, nasal cannula 2 liters per minute, face mask 15 liters per minute. Okay. Aiming to SpO2 94 to 98%. Then diuretics, furosemide, no need for dose, 1 mg per kg oral or by slow IV injection. Next is the amiloride. If on IV furosemide, check potassium 12 hoursly. Correct acidosis, hypoglycemia and electrolyte imbalance. Relieve pain with morphine. You can give for pain morphine. Then if anemic, correct the infusion with packed red blood cells over 3 to 4 hours. So cardiogenic shock, what do you do? Monitor central venous pressure. So he gave here already, if fluid is more than 40 ml per kg, you will monitor central venous pressure. Ensure adequate preload. Give human albumin solution 4.5% 10 ml per kg as IV bolus. And if not available, sodium chloride 10 ml per kg as IV bolus. If shock severe, see sepsis guideline. Start mechanical ventilation with positive and end expiratory pressure early and pulmonary edema present, start urgently. If shock severe, give early inotropic drug support such as dopamine, dobutamine, adrenaline or non-adrenaline as per your protocols. So he has used only this much. Inotropic support. Next is drug-dependent heart disease. That is maybe present in first 2 weeks of life. Drug-dependent systemic circulation, breathless, gray collapse, poor pulses. The causes is severe coarctation of aorta, critical aortic stenosis and hypoplastic left heart syndrome. Drug-dependent pulmonary circulation, you will have the baby blue, that is cyanosed, breathless or shocked. Here mainly they are breathless, gray, collapsed and poor pulses. Here they are blue and shocked. You have pulmonary atresia, critical pulmonary stenosis, tricuspid atresia, Fallett's tetralogy and transposition of great arteries. Okay, this cyanotic congenital heart disease. Okay, so I think we will end today. Hello?
Yes, we can finish.
You read, right? This cyanotic congenital heart disease.